Welcome back, everyone. Today we are looking at something that seems small, just a fingertip, but can turn into a surgical nightmare if you miss it. Imagine a patient walks in, maybe a tailor or a gardener, and they've got a throbbing, red, swollen fingertip. They think it's just a minor splinter, but you're looking at it and thinking, this is a ticking time bomb.
Exactly, Dr. Khan. In medical terms, we're talking about a felon. It's a deep infection of the pulp space of the fingertip. For the boards, you have to understand the unique anatomy of the distal phalanx, because that is exactly why this infection is so dangerous compared to a simple skin infection.
Right. It's all about the closed compartment. Think of the fingertip not as a soft pillow, but as a series of tiny, pressurized rooms. Sarah, tell us about those fibrous septa. That's the high-yield part, right?
Spot on. The pulp of each finger is actually divided into numerous small compartments by strong fibrous septa. These septa run vertically from the skin all the way down to the periosteum, the skin of the bone. Because these septa are so tough and inelastic, they don't stretch. If bacteria get in there and start producing inflammatory exudate, the pressure doesn't just spread out, it skyrockets within those tiny rooms.
It's like a honeycomb made of steel. If one cell fills with fluid, the pressure in that cell becomes immense because the walls won't budge. Now, Sarah, why does this matter clinically? Why can't we just wait for it to ripen like a normal pimple?
Because of the blood supply. This is a classic board exam question. The terminal branch of the digital artery, which supplies the shaft or diaphysis of the distal phalanx, actually runs through this pulp space. When that internal pressure rises above the arterial pressure, it cuts off the blood flow. It's essentially a localized compartment syndrome.
So the bone literally starves to death. It's like a kinked garden hose inside a concrete wall. If that pressure stays high, the bone dies. We call that avascular necrosis. But here's the interesting anatomical quirk, Sarah. Does the whole bone die?
Actually, no. And this is the detail they love to test. The epiphysis, the base of the distal phalanx, receives its blood supply proximal to the pulp space. So even if the pulp space is under massive pressure, the base of the bone usually survives. But the shaft, that's at high risk for necrosis and subsequent osteomyelitis.
That is a great distinction. Clinically, this is why these patients are in so much pain. The pain isn't just from the infection, it's from the tension. They'll describe it as exquisite tenderness. If you touch it, they might jump off the table. As a physician, you want to be their doctor of choice, and the way you do that is by recognizing that this needs immediate decompression.
And when you talk about decompression, you're talking about an incision and drainage, or I&D, but you have to be careful with your technique. You need to divide those fibrous septa to truly release the pressure. If you just do a superficial poke, you haven't fixed the problem.
Exactly. You're essentially opening the rooms of the honeycomb. Often, we use a lateral incision to avoid the highly sensitive tactile pads of the fingertip. But we have to mention the biggest trap on the exams and in the clinic, herpetic whitlow. Sarah, how do we distinguish a felon from a whitlow?
This is a massive must-know. A felon is bacterial, usually Staph aureus, and it's firm and tense. Herpetic whitlow is viral, caused by HSV, and it usually presents with small, clear vesicles. Crucially, the tissue in a whitlow is usually soft, not tense. If you mistakenly perform an I&D on a herpetic whitlow, you can cause a secondary bacterial infection or even systemic spread of the virus. Never cut a whitlow.
That's the golden rule. See vesicles, put down the scalpel. So why does this matter clinically in the long run? If we miss a felon or treat it too late, the infection can actually track back. It can involve the digital synovial sheath, leading to tenosynovitis. Now you've gone from a fingertip problem to a whole hand problem.
And once it reaches the synovial sheaths, it can travel all the way to the wrist, especially if it's the thumb or the little finger, because those sheaths often communicate with the radial and ulnar bursae. It's a domino effect of anatomy.
It's amazing how a simple pinprick can lead to losing function of the hand if you don't understand these closed spaces. Dr. Sarah, give us the high-yield wrap-up for the students.
Here are the 3 big takeaways. 1. A felon is an infection of the closed pulp space divided by vertical fiber septa. 2. Rising pressure can cause necrosis of the diaphysis of the distal phalanx because its blood supply runs through that space, but the epiphysis is spared. And 3. Always differentiate it from herpetic whitlow to avoid unnecessary surgery.
Perfect. Respect the fingertip, understand the pressure, and keep those digital arteries flowing. Thanks for finding us today.